Hi, it's Dr. Centeno, and thanks so much for joining me this evening. Over the next few weeks, I'm going to be doing these Thursday Facebook Lives. I think as I explained, I got a lot of travel coming up this weekend. I've got to go give a lecture to a bunch of physical therapists on craniocervical instability out in Reno. And then some other family responsibilities coming up as well. So we're going to be on Thursdays. Today we're going to talk about the top 10 things you really need to know about if you're going to consider stem cell treatment for craniocervical instability. And the reason why I'm doing this one, as usual, usually there's something that went on that week that kind of prompts me to want to focus on this topic. And I've just seen a lot of patients a bit confused about what's important when looking at stem cell treatment, what's not important. And so I just wanted to try to clarify a few things. As usual, I'll spend about 10 minutes or so going over this information, and then we'll go into Q&A mode. Regardless of where you are, whether you're on Facebook or YouTube, you can join in with questions. Just type those in the comments where you are, and I'll see them here. So again, if you're just joining us, the focus today is the top 10 things you have to know about if you're considering stem cell treatment for craniocervical instability. Again, I'll spend about 10 minutes going through this, and then I'll do Q&A if you're on YouTube or if you're on Facebook. Just go ahead and type your questions in on the comments, and I'll see them here. And then I'll get to them when we're done with this sort of opening content. So it seems like we've got people streaming in, so I'll get started on the topic for today. The top 10 things you have to know about if you're considering stem cells for craniocervical instability. So going to go through these one by one, but this is sort of the top 10 list here. Where and how you place these cells matters quite a bit. Avoid IV stem cells if you're in this category. We're going to talk about autologous versus allogeneic, umbilical cord products and what's going on there. Why PRP works most of the time. Talk about the fact that bone marrow concentrate is pretty pro-inflammatory. Get into what a stem cell or a nucleated cell count is. So if you see that number, if you're getting treatment in my office, what does that number mean? What a proper bone marrow aspirate looks like versus a really bad one, because if you get a bad one, you don't have as many cells. So you obviously want to avoid that. Taking bone marrow from the iliac crest versus the tibia, and then we'll talk about meds that impact stem cells. So that's kind of the agenda for this evening. Again, if you're just joining us, we're going to go through this content for the first 10 minutes or so, and then after that, open up the floor to questions. If you are on YouTube or on Facebook, just go ahead and type your questions in on the comments, and I'll see them here. We got some questions starting to come in now. So first I want to get into what is my authority to give this talk. I'm really at this juncture one of the world's best published authors on stem cell treatment for musculoskeletal disorders and spine. This is the list of my publications, which I think is actually missing one because we just had another one published. It was our ACL ligament randomized controlled trial. Obviously, this is a long list, so it's impossible to read these and see what they are, but you can scan this QR code with your phone. And if you scan that QR code, it'll take you to a website that goes through all of those different things. So you'll be able to see a PDF of a big list, and you can see what I've published on, etc. So where and how you place these cells matters. I think a lot of patients believe that stem cells are a little bit like magic, right? That they are told by providers, well, I need to kind of put them someplace in the general vicinity and they'll go where they need to go. Regrettably, that's not really true. What really happens is they tend to attach, mesenchymal stem cells tend to attach to the local tissues, and once they're attached, they're attached. Now, some of them will migrate a little bit, but the goal is to allow them to migrate millimeters here or millimeters there, maybe a centimeter, but it's not to have them migrate feet or inches. In fact, that all gets into the type of matrix or structural matrix in which they're injected. You don't want that to be a tight scaffold. You want it to be a loose scaffold where they can move around a little bit if needed. So it's important then to realize that these things are not equal, right? A blind posterior injection is nothing like an ultrasound-guided posterior ligament injection, which is nothing like a fluoro and ultrasound-guided injection from C2 to C7, which is nothing like advanced fluoro and ultrasound-guided injections from C2 to C0 using digital subtraction angiography, which is nothing like an EPICL. So at the end of the day, you've got to put these things where you need them. They're not going to magically go where they are needed. In this particular space, avoid this concept that somehow magic IV stem cells are going to go from your arm vein into your ligaments. In reality, there's multiple studies showing there's what's called a pulmonary first pass effect. And this means that 97% of these will end up in your lungs. Very few, if any, will end up in your neck ligaments. So this is really a scam. There's no reason to do this with this type of problem, craniocervical instability. Let's talk about autologous versus allogeneic. So autologous means your own stem cells. And the way I say it is your own stem cells stay and play. And allogeneic means someone else's stem cells. So with regard to someone else's stem cells, they're destroyed by our immune system shortly after they're put in. They do, during that brief period, give off some growth factors, paracrine signaling, exosomes, etc. But then they get taken out by the host's immune system. So this is actually a table I put together of all the different research showing that autologous stem cells last for as long as you want to look. All of these studies were at the maximum of the amount of time they looked, and the cells were still there, meaning the patient's own. But if they were someone else's stem cells, they didn't last for long, a couple days on average, or maybe a week before they got taken out. So they don't really stick around. And that's one of the problems of using someone else's stem cells. Now, will we solve that problem eventually? I'm sure we will, but we don't have a solution for that problem right now. Number 4, umbilical cord products have dead or dying cells. So this is a big one, right? It's one of the bigger scams that has ever been perpetrated on the American people, and it continues to be perpetrated to this day. And that is that there are these products that you can buy, or that doctors can buy, that have things like Wharton's jelly in them, which is the jelly content from the umbilical cord, and then that's a stem cell product. And you can go to these dinner seminars and they will tell you that these are young, vibrant, plentiful stem cells. So we looked at this a long time ago. And a long time ago, we saw the first product that we were sent. We tested. We've got a state-of-the-art university lab. It's got $1 million worth of lab equipment in it. This is just the research lab, not the processing lab. And we've got scientists, and they looked at the product, and all the cells were either dead or dying. Then we got another product, and dead or dying. And eventually, we did this paper where we got 5 of these products. And what you see up here is all white, means all dead. And then this is elderly bone marrow. These little dots that you see here, these are CFUF colonies from stem cells from elderly bone marrow, compared to the all white equals all dead from the 5 umbilical cord products we tested. And this paper was published in the world's, arguably one of the world's best orthopedic journals, the American Journal of Sports Medicine. So at the end of the day, don't buy the scam here. Next one is properly dosed PRP often will get the job done. So we'll use PRP quite a bit, but it's got to be properly dosed. So what that means is that if you're young, you can have low dose PRP work very well. If you're middle-aged, you need high dose PRP. And if you're older, you need very high dose PRP in order to get the job done. But there are many times where we will use PRP because it'll work about as good as bone marrow concentrate for certain applications. It's going to underperform in ligaments, so we don't use it, for example, during a PICL procedure, but it'll do pretty nicely, for example, in a degenerative joint, like a facet joint. Bone marrow concentrate is very pro-inflammatory, so that means that you really wouldn't want to use it directly around nerves. That could be a bad day for everybody. In addition, you can use it in things like facet joints during a PICL procedure, or in just treating the upper neck facet joints. The big problem there, though, is where the patient can tolerate it. Not all patients can tolerate this. Some patients do just fine with it, and if you've got a more sensitive patient, they're going to know the difference between putting bone marrow concentrate or bone marrow stem cells in their facet joints versus leukocyte poor PRP. And the good news is, if you're going to look at anything for treating ligaments, bone marrow concentrate of all the different stem cell things you could use has the best data to date. We've published a good portion of that data in some of our ACL studies. Hey guys, if you're just joining us, give me a like, comment, share, subscribe, because that's how people find this content. If you want to pay it forward to the CCI community, i.e. have your friends and others that you know online find this content, then you got to do that so that will support the algorithm in showing this content to them. So what is a TNCC? So many patients come into the office. They're always asking about, what is my stem cell number? And we give them a total nucleated cell count, or TNCC. TNCC is just the total number of cells in the sample. And of that, a small percentage is the stem cells. Now, the good news is, in general, the higher the TNCC, the higher the stem cell count. The only time that can become unhinged is when you're very young. And there's really no relationship between TNCC and the EPICL outcomes that we have seen so far. But when you see this number from us, this is what this means. A proper BMA versus a bad BMA. And this is a big one that I see a lot. And that is, it is hard as a doctor to do a really good bone marrow aspiration. Why? Because it takes time. You've got to go to multiple bone sites and multiple depths per bone site, take a tiny amount of bone marrow, and then move on to the next site. And to do a proper bone marrow aspiration in a very experienced provider is going to take probably 25 minutes. To do it with a less experienced provider, probably 35 or 40 minutes. Having said that, you could make this as a provider take 2 minutes. And to do that, you would just stick this thing in one time and realize a bone marrow aspiration is where we're taking a trocar, which is what's shown there, and we're working it through the bone. Most people think of bone like hard cement. It's really more like soft plastic, so you can work it through the bone. And if you want to make this take 2 minutes as a doctor to maximize your income, because the patient doesn't really know any different, then you just take the amount you need from a single site. The problem is that's going to dramatically reduce the number of stem cells you get, because anything you're pulling beyond 2 or 3 cc's, a little tiny amount, is just peripheral blood. So you're not pulling stem cells. So again, most of the doctors doing this stuff do it that way because the patient doesn't know the difference. And I can make this take 2 minutes and get paid the same amount of money as the doctor. Now, we don't do that at Centeno-Schultz. We don't do that in the Regenix network. If we catch someone doing that in the REGENXBIO network, they're out of that network. So we focus on the kind of draw that will maximize the number of cells. That takes more provider time, but is better for the patient. We want as many cells as we can get. Here's another little gig that's going on out there. We see a lot of providers, or at least a reasonable number, who will try to take bone marrow from the tibia versus the posterior iliac crest. The posterior iliac crest is sort of the back of the pelvis there. Now, the problem is that we've known for a long time that the tibia is relatively stem cell poor. So that dog won't hunt, right? If I know that if I take it from the tibia, there are half the number of cells for the same volume as if I take it from the posterior iliac crest, then why would I take it from the tibia? Well, it's pretty easy. In addition, it's almost impossible in the tibia to take it from multiple sites. So you only get one site. So in general, when you're taking it from the knee area of the tibia, you are dramatically robbing the patient of stem cell content versus taking it from the posterior iliac crest. And then finally, lots of meds impact stem cells. So the top 5 meds that kill stem cells, marcaine, bupivacaine, which are local anesthetics, lidocaine as well, all steroid medications, all corticosteroids, whether those be IV, oral, the ones that go up your nose, the ones that you inhale, etc. ACE inhibitor blood pressure medications are also in that same category. That's mostly lisinopril. And biologic anti-inflammatories ending in MAB for monoclonal antibody. So those are the things that you really shouldn't be on if you're getting a stem cell procedure. Now, there are also things that inhibit stem cell repair, and that would include non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, Motrin, Celebrex, Aleve, and the CGRP migraine medications as well. The CGRP migraine medications are some of the newer migraine medications. And then rheumatoid arthritis meds like Plaquenil. Now, we have a long list which you sign up for a procedure that you can go through to try to determine if the medication that you're on, and I think it's 130 medications that are on that list, is on the list and what you need to do and when you need to do it. But it's important to know that you should be checking the meds that you're on relative to the procedure. And if the doctor's not giving you that information, that's a problem, because you may well be on a medication that will negate the effects of the stem cell procedure you're trying to get. Okay, we're going to go to Q&A now. Again, give me a like, comment, share, subscribe if you haven't done that. That's how patients find this content. And we want as many CCI patients to find this, because we want all of those CCI patients to eventually join us here to get their questions answered. So let's go with the first question here. Hi, doctor. If you have a disc herniation at the C4-5 level, at the C3-4 level, would you be concerned of CCI? Not usually. Now, theoretically, C3-4 might cause upper cervical symptoms, less commonly, but possible. But no, that wouldn't be related or directly related to craniocervical instability. I've had head pressure, and my left side of my head twitches a lot, especially on top of my left ear and behind it. Is this a nerve issue or could it be a blood circulation issue? Usually twitching in a nerve, twitching in a muscle is nerve related. So at the end of the day, my sense would be the first thing you would look at is whether or not there's a nerve going to that specific muscle that could be impacted. Primster, if I have herniated disc C2-3, does PICL help that resolve? Depends on what it is we're talking about there, meaning that if that's symptomatic, then then a PICL procedure would add in potentially treatment of that 2-3 area. And consequently, we would expect the symptoms from that area to go away or reduce as well. But I would need to know a little bit more about what it is we're talking about there specifically. I started to develop some right eyebrow and eyelid drooping. What can cause this symptom in CCI? Well, the first thing is you want to make sure it's not other things like Bell's palsy. You want to make sure that it's not other things involving cranial nerves, that you've had a clean brain MRI, that there are no issues with regard to other neurologic conditions like ALS, etc. Assuming all of that has been ruled out, and you've got sort of eyelid drooping issues, then it could be cranial nerve related and related to CCI causing irritation of that cranial nerve. But again, you want to make sure that you're ruling out any of the really bad problems, like a brain tumor, for example. Vero, hideout Centeno. Since my neck and brain injury, I get a weird bubbling, tingling sensation in my teeth and head when I read or watch TV or put a hot pad on my neck, upper back. Could that come from CCI, perhaps from the trigeminal nerve? The dentist says my teeth are fine. Yeah, so in particular, the V2 and the V3 portions of the trigeminal nerve, which can be irritated in CCI patients, go into that teeth area. So that one can happen, yes. And that can be interpreted as sort of weird sensations in that nerve territory. Greg, does Klonopin cause issues with stem cell count? Not issues with stem cell count, but Klonopin can be a little bit of a problem with anesthesia. So when we're talking about IV anesthesia, if you're on benzodiazepine drugs like Klonopin, it's going to make anesthesia harder, meaning higher medication doses to keep you asleep relative to other patients. And anytime we use higher doses of anesthesia, there's always the possibility of increasing risk from the anesthesia itself. Lisa, hello, Dr. Centeno. I'm having my third PICL in January. I just started to hold Dr. Rose's adjustments longer. Great. I was notified today that I required an endoscopy biopsy of the cyst in my common bile duct. Is it safe for me to do? Can I do anything to protect myself from damage? Yeah, Lisa, thank you for joining us here this evening. I know I had wanted you from the Reddit thread to go ahead and come on here and ask this question, because this is a question I get all the time. If you're going to have some sort of surgery, how do you protect yourself if you have CCI? And I think the easiest way to do that is to wear a cervical collar into surgical prep and into surgery, and talk to the surgical team about the fact that you've got a bad neck, and if they're going to move you or turn you, that you prefer that you keep the cervical collar on. Now that does two things, right? The first thing it does is there may be some protection of your neck with the cervical collar during the procedure. The second thing it does is it's a constant reminder to the surgical team that this particular patient has something going on with their neck and we need to be careful. So that's my recommendation for all surgeries for CCI patients, is wear that cervical collar and talk to the team, but make sure you keep it on if possible during the procedure. Now they may need to take it off at some point if they're working in that area, but at least you're forcing them to take it off so they know, again, they're being constantly reminded, neck problem, neck problem, neck problem. How important is a good back and neck posture in CCI? Very important, because if you've got a forward head posture, then that's going to put more weight on the upper cervical structures. Ali, how common is dissociation derealization in CCI patients? What's the most likely cause of that? We do see it a good amount. It's believed that it's related to the issues with proprioception or position sense in the upper neck. Now, lots of other things can cause these symptoms. So like many symptoms in CCI, you need to meet with medical specialists first to make sure that there isn't another cause, for example, of dissociation or derealization. If they're stumped, then it could be a CCI related issue, and it's probably related to decreases in overall position sense. Ryan, do people who don't have an injury caused due to CCI and are at least living in a functional bubble have better success rate with PICL? I don't have a normal life, but can still walk and drive. So I think the first question, Ryan, is whether or not people who don't have an injury causing CCI, so then the other cause would be hypermobile Ehlers-Danlos, do better or worse, about the same. Then the second question in here is, if you are more functional than the average CCI patient, are you going to do better? And in general, I think the answer is yes. I always tell patients that the deeper the functional hole is that you must climb out of to get back to normal, the harder it is going to be to get back to normal. So if there's just a very small delta between where you are and living in a functional bubble, i.e. not normal, but you can construct a world in which you can function, then it's going to be less to get you back to full function than someone who, for instance, can't get out of bed. Amain, is it possible to restore a neck curve without before treating CCI? You know, I always recommend that patients try that. They're going to fall into one of two categories, and this is what I discuss in the rehab videos, and that is a collar test. And that is a towel test. A towel test is where you go ahead and you take a small hand towel, you roll it up, and you put it sort of behind your neck here, and you lie face up on that. Now that's going to artificially slightly increase the curve. And you're going to fall into one of two categories. You're going to say, wow, that feels great. That feels like something I should do. Or, wow, that really flares me up. If it feels great, then you might want to consider curve correction and finding a curve correction provider out there. Those are at idealspine.com. If it makes you much worse, then you're in that category of CCI patients that just can't tolerate that kind of stuff until you get stabilized and get treated. Carrie, hi Dr. C, have you found any changes in immediate post-procedure pain levels since introduction of the 5th gen mouthpiece? Yeah, we have, Carrie. In fact, I've had a lot of patients say that. I'll give you a great example just from this week. We had a patient who really had a rough recovery with the first one, and she had had just a prolonged recovery cycle of months before she got back to normal. Ultimately, she felt a bit better, but first thing she said when she woke up with the 5th generation mouthpiece, which was just this week, was, wow, this is so much different than before. And what she meant was that we'd actually done more injections this time with the 5th generation mouthpiece than we did with the prior mouthpiece. But just the last one, she felt more beat up, more sore right after the procedure. So realized at the end of the day that we were able to do probably 3 times as many injections, or at least double, and she felt less sore. Why is that? Because the 5th and 5.5 generation mouthpieces manage the airway much, much better. And by managing the airway much, much better, they just reduce the amount of issues we have doing the procedure. And I think they also reduce the amount of mechanical manipulation we're doing to constantly refit the mouthpiece, reestablish the airway, etc. So at the end of the day, yes, it seems to be making a big difference. Alex, I'm high functioning, full-time work, exercise half hour to hour, incline walking, sometimes jogging, have PICL next Wednesday. How long until I can get back on the treadmill? You know, Alex, it's again a thread the needle. Go through that whole rehab series that I have online, but the thread the needle concept is very important here, right? If you can function at that level and do those things, and you don't have major flare-ups in your symptoms, then you can continue to get back to those things relatively early. On the other hand, for example, is every time you try to run, you pay for it for several days, then running's out during your recovery. So hopefully that gives you some idea of how to thread that needle. Jonathan, hi, Dr. Centeno, how bad will CCI get? Untreated, will it kill with my dysautonomia? I don't know what that one means. Hopefully you don't mean that you think that your dysautonomia is going to kill you, because usually that doesn't happen in CCI, no matter how patients feel or how bad they feel. But in general, Jonathan, most CCI patients, if left untreated, will kind of slowly get worse in my experience. Now, some go the other direction, some can get better, and some can rehab out of it. So you probably see examples of people online who are able to rehab out of it without doing anything other than the rehab, which is fantastic. You should always try to do that first. But if you can't do it, that's obviously where we come in. Diana, will I still benefit from PICL if I have very big neck muscles that are not activating? Yeah, I think so, Diana. I mean, if you've got neck muscles that aren't activating, there's a reason why they're not activating. Usually the reason is instability or the other problems related to instability, like irritated upper neck joints, for example, irritated nerves, all of which would be treated during PICL. I mean, yes, I would like, or yes, like it would get better one day if not treated, and we will end up dead or handicapped. I don't think most CCI patients are going to end up dead from this kind of CCI. Diana, my neck feels like mush and not activating. Yeah, Diana, that's a common issue. We see bobblehead in CCI patients, basically the concept that the upper neck stabilizing muscles are offline and people feel kind of like one of those bobblehead dolls. So that's a common issue we treat with CCI, and eventually we can get that sensation usually to go away. Greg, should we be getting blood platelet count done before we show up for PICL? Not usually an issue unless you've got a history of anemia. Obviously, if you have a history of low blood counts, like a history of chronic anemia, then you may want to get that. But if you don't have a history of anemia, I wouldn't worry about it. Brent, can PRP injected the upper neck facet joints help with proprioceptive nerve regeneration? It's not really a problem, Brent, with proprioceptive nerves as much as it is the proprioceptors in the joint giving bad information. So proprioceptors in the joint giving bad information to the brain, and that then being linked to dizziness, imbalance, sometimes it's derealization, etc. So the PRP is to reduce the swelling in the joint so that the proprioceptors can come back online, but it's not so much damage to proprioceptors. Snow asked, hi, Dr. Centeno, what would be best for muscle injuries or tendons? For muscle injuries, we use poor plasma PPP because that's been shown to activate muscle stem cells the best. For tendons, more PRP because that's been shown to activate tenocytes the best. Linda, hi, Dr. Centeno, my PICL is about 10 days. And I just started to get a new symptom, tugging, pulling the top of my ears and inside my ears randomly. If I rub my thumb down the right side of my neck, I feel pulling on the top of the left ear and it gets tingly, a little numb. This comes and goes. Yeah, so Linda, that's probably the superficial cervical plexus underneath the sternocleidomastoid muscle. So there are nerves that come out behind the sternocleidomastoid. Sternocleidomastoid is typically tight in CCI patients, and those nerves can get irritated. That's probably the lesser occipital nerve, as it comes out from behind the sternocleidomastoid, and that's usually then treated as part of that PICL procedure. Carrie, how are stem cells separated from TNCC? I think the question here, Carrie, is what's the difference between a stem cell count and a TNCC count? A TNCC count is something we can do at the bedside. That just requires us to look at the total number of nucleated cells. A stem cell count would be much, much more complex. The most common way that's done is a CFUF. That's where we put the cells in culture, wait about 10 days to 2 weeks, let them form colonies and count the colonies. Obviously, that's not going to help us or inform decisions at the bedside. Another thing that can be done, we do for research purposes, is using a rare event flow cytometer and looking for CD271 on the cell surface. That's something we do for research purposes, but it is far too expensive to do on a patient-by-patient basis to look at their total stem cell count. So the best we can do is that total nucleated cell count rather than getting a stem cell count, but it's a pretty good proxy for the number of stem cells in the total sample. Jonathan, I've heard good things about you guys since I have undiagnosed dysautonomia and possible CCI and come for treatment. Will the outcome be terrible? Jonathan, yeah, I can't answer that question. I would need to know exactly what kind of craniocervical instability you have. 1A, 1C, 2A, 2B, 3A, 3B, etc. And then whether or not it seems likely or unlikely that that's causing your dysautonomia. Obviously, if there's a type of CCI that we can treat that's causing dysautonomia, then the good news is we generally see a reduction in those dysautonomia symptoms. But lots of daylight between obviously this question and getting to that point. Jamie, how should I be off, or how long should I be off Plaquenil before PICL, and how would being on Enbrel a year ago still impact my stem cells in theory? Enbrel a year ago probably doesn't still impact your stem cells. As far as Plaquenil is concerned, at least 6 to 12 weeks, somewhere in there. But Jamie, this is the kind of thing that's best to discuss with your specific physician and or the rheumatologist that's prescribed those medications, meaning that this is a discussion of the risk versus the benefit of stopping these medications. Allie, what's usually the cause when straining? It causes head pressure headache when you have CCI. Usually that's going to be more an internal jugular vein type issue. And it's pretty common for the IJV to get compressed as the C1, C2 becomes unstable. So that's usually an IJV compression type problem. And again, the goal there is to treat the CCI so the IJV is not continuously getting compressed. It's been advanced by Sherry Scott. If you are anemic, would you need to correct that before a PICL procedure? If so, can it be corrected with diet? Yeah, you would, although that's something that's a good question for the doctor that's treating you, meaning the first question is going to be is how anemic versus what are we trying to accomplish? So that means how much sort of blood is in the tank, if you will, versus how much do we need to remove from the tank to accomplish our goals. And we've got to align those things. Now, if you're very anemic, you might need to do things like iron supplements or other treatments in order to try to get your red blood cell count up. And there are other treatments and methods, diet, steaks over, for example, over oranges. Permistor, I have CCI, but also herniated discs in the neck and lower back, so you treat both during the procedure. We do treat both during the procedure, yes, pretty commonly. Jonathan, I've heard about PICL being effective, but the outcome varies or not at all, especially in dysautonomia patients. Yeah, Jonathan, I report the PICL outcomes on the Reddit sub. Used to be weekly, now it's going to be more kind of bi-monthly or monthly. I'll probably update that maybe if I have time tomorrow or this weekend. And you can see the outcomes there and see what those outcomes are. But I'd encourage you to join that Reddit sub. It's RPICL. So if you go to Reddit and join that Reddit sub, you can see those. Just look them up. You can see them from a couple of weeks ago. Obviously, I'll be posting them as I go as well. Vero, can nerves communicate among each other? For example, if the TON is irritated, it can also irritate other occipital nerves, trigeminal nerve. Yeah, Vero, I think there's some concept here that in some patients we do see when one upper cervical nerve gets irritated, it can affect the upper cervical ganglia, which can then cause issues in other connected nerves. I have a video on that I did maybe 2 years ago, but ultimately the answer is yes, that a specific nerve in one spot, if it's an upper cervical nerve, may impact the state of other nerves in some patients. Carol, smooth advance by DA. Have you ever seen any muscle or nerve damage from oral gastrophin? You know, that's out of my area of expertise, so I really can't answer that one. Lisa, soft collar, okay. Yeah, Lisa, I would do as much as you can tolerate, right? I would get as stiff a collar as you possibly can. That's going to provide some protection. Vero, can nerves communicate? I think I got that one already. Aiden, I see in your presentation that lidocaine kills stem cells. This is mostly concerned with injections or with topical patches over the counter also be a problem. Topical patches can also be a problem. The bigger issue, though, is going to be a injection of lidocaine near or into the cells, or sometimes you'll see people combine lidocaine with stem cells or PRP, and that's the concern. That's the bigger concern. Gomer Barn Floyd, what do you know about MRI findings of neuroforaminal narrowing and superior vermian atrophy? I don't know what that term means, so maybe that's a typo. I think I have EDS and CCI. Neuroforaminal narrowing just means that the foramen or the hole for the nerve coming out, the spinal nerve, is smaller than usual. That usually doesn't have anything to do with CCI. That's sort of common everyday degenerative changes that happen in a lot of patients. The question is that causing your specific symptoms? So a doctor needs to look at that MRI, say this is the nerve that should be impacted by that, do an exam and see if that nerve is being impacted. But there isn't usually any neuroforaminal narrowing as part of a CCI conversation. JS is a nerve or muscle in the neck maybe that causes tinnitus, pain in the ear, and eustachian tube issues. My hearing is dimmed. Yeah, JS, if you go on the YouTube channel, so if you go on my YouTube channel and you just type in ear there's a bunch of different videos that will come up about different nerves that can get irritated that can cause ear issues in CCI. Ryan, can you inject things like a wrist problem with stem cells if needed during PICL procedure? We can, Ryan. I usually prioritize kinetic chain problems. So for instance, problems, let's say in the upper cervical spine, lower cervical spine, maybe SI joints. Now for just doing the PICL and you want your wrist injected, there's probably enough time to do that. One of the things I try to dissuade patients from doing, though, is coming in with a laundry list as long as my arm of different areas they want injected. I would generally recommend they get those other parts and pieces injected locally. And I will do during the PICL either what I've got time to do or prioritize kinetic chain problems. A kinetic chain problem, for instance, might be the upper cervical spine and the SI joints, opposite ends of the system. Linda, my occipital neuralgia has returned the past 2 or 3 weeks since April. I'm not sure if this comes from the shoulder shock wave, colder temperatures, jackets, touching occiput, which, Linda, I don't, again, this isn't really that kind of situation where I can try to figure that out for you, given all the different parameters of what causes that. That's not really a question I can answer in this type of forum. Carrie, great news about the 5.5 mouthpiece. Have you also been able to reduce the need for high flow? Yes, Carrie. So in general, the amount of high flow oxygen that we have to do has gone down quite a bit. Allie, wishing in ears also when straining. Yeah, so again, Allie, that tends to point, the pulsatile tinnitus tends to point more in the direction of IJV, in that that's usually associated with IJV problems or internal jugular vein. Alex, what I meant was, does it damage the freshly treated ligaments if I were to walk, jog too fast? Not in general. Again, use that thread the needle approach. Diana, can it also be from muscle atrophy? I feel like it has something to do with it. Is it treatable? Yeah, Diana, muscle atrophy is common in CCI patients, and we can treat the cause by treating the CCI or other structures that have issues, and then the patient works on neck strengthening. In general, the neck strengthening isn't working because the other issues haven't been treated or solved. Diana, is an overhang of 4 considered a candidate for PICL? It is squarely in that PICL range. Aaron, hi Dr. Centeno. Do you recommend that patients see Dr. Rosa before or after PICL or both? Yeah, Aaron, I always tell patients, love what Scott Rosa does, love getting information from Scott about what he thinks needs to be treated based on his imaging. Scott does very advanced imaging, so I would say happy to work with Scott either before or after. So we go through a number of different processes. The first process is, are you qualified for a PICL procedure or something else? So if you've met that hurdle, for example, with the DMX, then there are times that we will then require an upright MRI, but not always. Now, having said that, I always tell patients, I'll never turn down more information. I'll never turn down information from Scott. So if you want to see him before or after, I would love to see that data and information that he can put together. Brendy, how can patients reduce the chance of prolonged inflammation of the upper neck joints after a PICL? Is there a chance of degrading the joints even further, or is that usually not the case? Yeah, usually not the case. The biggest issue there is identifying which patients are essentially sensitized up front and then using a less is more approach with that patient. Mrs. Whoosh, what up, doc? Post PICL2 going well. Anticipate seeing you for a third. Take care of yourself. Thank you. Glad to hear that things are going well after number 2. Jonathan, how does CCI affect immune response? I've noticed since the neck affect function in the body. Yeah, Jonathan. So there's definitely a connection between vagus nerve issues and the immune system. In fact, one of the big companies, I believe it was Medtronic, just got FDA approval for a vagus nerve stimulator implantable one that to treat rheumatoid arthritis by impacting the immune system. So in CCI patients, it would be the same. Irritation of the vagus nerve can impact the immune response. Vera, my old back pain flared up considerably with my neck injury. Why would that happen? Does back pain usually go away? Yeah, so we know based on a few different studies that when patients have chronic neck pain, it impacts the ability of the low back to stabilize itself. So obviously, if you then had sort of a chronic low-level low back issue and you lose low back stability because of a chronic neck issue, then that back problem is sort of going to reassert itself because stability is a major thing that protects the back. Diana, I'm also suspecting I have cranial settling, can also be from long-term CCI and AAI. It sure can, but again, Diana, I would encourage you to kind of get a diagnosis there because cranial settling is something that can be diagnosed on an upright MRI, for example, fairly easily. Mrs. Whoosh, I know it would be hard to measure but just in your opinion, would a patient need to get a certain millimeter range to see improvement, especially if they have severe overhangs? No, regrettably, we don't see a connection there. I know we had some crazy social media influencer guy claiming that there was some sort of connection between reduction in overhang and symptoms. We don't see that, meaning that I've got a whole case series of patients who we saw a really nice reduction in their overhangs and had no change in symptoms. So realize the overhang is a way to identify that the problem is there, and we hope to see reductions in those overhangs. But the reduction in the overhang isn't necessarily related to a reduction in symptoms. Why could that be? And that's because for many patients who have had this problem for a while, we tend to see irritation and damage of nerves and or joints, and that irritation and damage of those structures is what's causing the symptoms. So at the end of the day, you can get rid of the instability, but you still have damaged structures, so you still have symptoms. It's one of the reasons why during a PICL procedure, we treat all of those damaged structures as well. Permister, CCI curable, can you return to combat sports? Have we had patients, for instance, return to judo? One I can think of offhand after treating their CCI with PICL? The answer is yes. Combat sports could be a stretch. I'd have to know more about what combat sports means. Brent, in the future, do you see a CSC ever offering other CO treatments on site, such as curve correction, posture correction, PT? Notice that all physicians that offer this don't always understand CCI. Probably not. We're very, very focused in the world in which we live, which is the interventional orthobiologics management of craniocervical instability. We treat lots of other things as well. And we're very focused, I'm a laser focused guy, and that's where I'm going to keep us. Greg, looking at vagus higher dissection during PICL, can you only do one nerve hydro, or can you treat ganglion and or other? If you mean, can we only do one side? No, we routinely do two. If you mean, I think, can we treat a stellate ganglion at the same time? That's possible. Vero, is having a small mouth an issue for the PICL? How can we tell if our mouth would be too small? Unlikely to be a problem. We just had a patient with a really small mouth who had difficulty opening because her jaw dislocated. We were able to accommodate that. We've had several patients with that same concern. We were able to accommodate that. So I think it's probably unlikely that we're going to be in a situation where we can't use the mouthpiece because the person's mouth is too small, because we've got multiple sizes available. Diana, can this make you lose your appetite or lose your appetite completely? I don't even get hungry anymore, and it's getting harder to talk for a long time now. Is it connected? Well, Diana, lots of things can cause you to lose appetite. So I would encourage you, for instance, to rule out depression. That's something that can have you lose appetite. But assuming all of that's ruled out, then yes, vagus nerve irritation and CCI through gastroparesis can cause a loss of appetite and weight loss. So listen, at the end of the day, you've got to rule out all the common things that cause symptoms like that. But that is one that can be related to CCI. With the growth of AI, how do you see CSC leveraging it? Quite a bit. I'm using AI a lot right now, using it to do some of our medical literature searches now that I know how to hold its feet to the fire and get the information I need, using it to vibe code entire pieces of software that we're using in the clinic. For instance, I vibe coded an entire electronic health record that we're going to deploy here in the next month or so that is specific to our workflow and specific to CCI. in order to keep all the doctors rowing in the same direction, etc. So I am a huge AI user and believer. I don't think we're going to recognize 2035, to be honest with you. I think, as I told my kids, we will see more changes in the next 10 years than we've seen in the last 1,000 years. And I mean that because we've never been in a situation where we could scale intelligence, and intelligence could be purchased for pennies on the dollar. And it's going to have profound impacts on society, some of which we are not ready for. But the good news is, at the end of the day, we'll get to the other side as a society. It'll be pretty cool. Thank you for your time and knowledge. Greatly appreciated. Thank you, Greg. I have an MRI of my lower back 4 years ago, 2 or 3 months after injury. Is that still relevant to use now? Yeah, I would say that a lot depends on whether or not your symptoms have changed. If your symptoms have gotten worse, then I would say get a new MRI. With regard to brain fog and anxiety, if those are being caused by CCI, then yes, they generally tend to calm down, but lots of other things cause brain fog and anxiety. Jonathan, why are doctors so dismissive of CCI, even mentioning it to them? They then say it's in your head. Jonathan, I think it's just a matter of finding the right doctors that do this work all day, every day. I always bring up the surgeons, right? There are 5 surgeons on earth that see most of the elective CCI fusion cases. If you were to go to not one of those 5 surgeons, you're going to get dismissive stuff. If you happen to go to one of those 5 guys, they're going to be like, oh, yeah, I know what you have. This is what you have, and this is what we need to do. It's like anything else that's hyper specialized. There are a few hyper specialists out there. And what's unique about CCI is that most of those hyper specialists for things like cancer, for example, are in large university medical centers. CCI, not the case. So it's similar to other areas of medicine. So for example, I'm sure there's a guy that specializes in the surgical treatment of stage 3 pancreatic cancer with A, B, and C out there, and he's the best in the world at that. And he's going to view that problem differently than the average general surgeon. So it's the same thing. Diana, a sore scalp, head comment, CCI. I can't even grab my hair up anymore. Yeah, Diana, that's pretty common when you get occipital nerve irritation in the suboccipitals here with CCI. That can cause sensitization. It's also common with C1, C2 types of CCI. So for example, type 2B, where we see excessive rotation of C1, C2 due to alar accessory, and that can lead to irritation of the C2 dorsal root ganglion, which can also cause that sensitivity in the scalp. Brent, in terms of muscle neck atrophy, is there any point of no return where atrophy is so bad it may warrant a fusion? Usually not, but again, it's always possible that the CCI has progressed to the point where it can't be treated through injection. So that's why this wouldn't be 100% effective. So for example, for every 10 patients we see, depending on the patient, somewhere between 7 to 8 out of 10 are going to have a great response, and about 2 to 3 out of 10 are not going to respond or not going to respond enough and would need to move on to something like a fusion. Veronica, how soon can one see benefits for brain fog and anxiety? Well, if they're being caused by vagus nerve related issues, then within a number of months, somewhere in that area. Okay, guys, I'm going to take 1 or 2 more questions because we're starting to run out of time here. Primister, my symptoms of brain fog, anxiety, dissociation, numb emotions, bad memory, fatigue came 1 to 2 months after injury, as well as numbing legs and urinary retention. Yeah, so those are the kind of things that you would want to review during a telemedicine exam so we can try to see if those are all related to what's going on in your neck. Jonathan, can TMJ disorder twist your upper spine? It's possible, but usually it goes the other way. Usually the spine impacts the TMJ. but TMJ can impact the spine as well. And Diana, can this cause dementia symptoms? If you mean brain fog, yes, but again, lots of other things cause brain fog, so you have to get all of that other stuff ruled out. Okay, guys, we are right at 5 o'clock, so I'm going to end this Facebook Live. If you could, before you log off, give me a like, share, comment, subscribe, because that helps patients find this content. If you want to pay it forward to others that you know in the CCI community, if you do that, they'll be able to find this. Otherwise, they'll never be able to find it. Thanks so much for all the great questions. We learn really good stuff by people asking questions and another patient saying, oh, yeah, that's like me. Appreciate you trying to get used to the new time here. I know it's not perfect. But again, I got a lecture this weekend to some physical therapists on CCI, so hopefully I'll be able to mint lots of new providers out there that won't look at you like you got an eye in the middle of your forehead when they see you, and they'll say, oh yeah, I remember that Centeno guy talked about CCI, that's what you probably have. So it's for all good, and then I've got some family stuff to do for the 2 weekends after that, and then we'll go back to do our Sundays where we normally put this on Sunday mornings. Thanks so much for watching today. I want to make sure everyone has a wonderful week, and I'll see you back next week. Same bat time, same bat channel. Thank you.